Hello, everybody. Good evening. Thank you for joining us. Um, for those that you don't that know us, I'm on the East Coast and Josh is on the West Coast. So I've had time to go home, shower, play with my dogs, lay by the pool, and now I'm back here ready to work. And poor Josh has just come off seeing patients. So,
We're okay.
but we're okay. I'm better, but we're okay. So we just want to thank everybody for being here tonight. We're going to go ahead and get started. We have a lot of things we'd like to cover tonight, and we want to respect your time. And like Jordan said, it used to be called, we used to have a beginner one called, we called it like the intro course, and then we had the mastering course. And over time, as more people are getting exposed to these devices, we feel like we can put a lot of this information into one webinar that would benefit everybody. And so we are now, instead of calling it the Master's Advance, we're now calling it the Mashup. Right there. So we're going to jump right in. Again, my name is Ann Bynum. These are all my thingies. I went to Florida State. I went to Iowa. I did peds in San Antonio in a building that's been bulldozed. And I've been in practice actually now going on 30 years. I'm going to my 30th class reunion at Iowa in September. And I've made every mistake in the book. And that is what gives me the most street credibility to speak on things like this tonight. Because when I got these devices in my hand, there weren't webinars for me to look at. There weren't other people to call. It was a very small amount of people piddling around with these devices. And so I feel like my goal with everything I lecture about and try to help other practitioners with is to keep them on a shorter learning curve. And that's my goal with these devices tonight. I'm married to Matt. He is my business partner and I guess my partner. He's my husband, and he's a general dentist, and we're in the same building. And he's actually downstairs. He got a new desk today, so he's putting his new desk together. And we've got three kiddos. This is Matthew. He's 26, engaged to Maddie. They just bought their first house last month. This is Luke. He is a D3 now at MUSC, does not want to do what his crazy mom does, wants to go with his dad. And Faith is his fiance, and they'll be getting married next year. But all these critters down here will be getting married next year. This is John. He's going to be a senior at Clemson. He just did a study abroad in Spain this summer. Every time I FaceTimed, he was on a rooftop bar. So if you're going to be sending your kids abroad, get used to seeing them on rooftop bars. And this is his girlfriend, Sal, and she plays rugby at Queens. So great men, great ladies, my greatest accomplishment right here, all in one slide. And then I have my practice as well. And Megan Churowski is my business partner. You probably heard her teach. She teaches for NuSmile as well. She teaches Restore courses, and she helps, keep the dumpster fires at bay here in the practice. And she's a full goat, and she's my 2.0 and just a crazy, loving, wonderful dentist and business partner. And then we have other docs. We have Dr. Maria and Dr. Nash, and it's one laugh after another. And if it ain't fun, folks, don't do it. That's the first practice management tip I can give you. That's a free one tonight. If it ain't fun, don't do it. And we have lots of fun. We go away every year for 3 days, and we work on ourselves, and we work on our practice, and we work on personal and professional goals. And you have to take your foot off the gas sometimes and do stuff like this and pour into your people. It's the best golden handcuff out there that I know of. I also run a tongue tie center. I run Holly Tree, and then I have a tongue tie and airway center that keeps me busy. Lots of things keep me busy, but this is one of my favorite things that keeps me busy because it really does change lives of kids and families. This is our practice. It got a facelift, it got a new coat of paint, and it got a $2 million expansion. So I'll be practicing for a long time.
Hi, everybody. Thank you so much for joining us tonight. My name is Josh Solomon, and Ann is definitely the fun one of the group. I have to be the more serious one. But I'm a second-generation pediatric dentist. I've been in practice since 2003, and my heart always goes out to those of you that did a startup like Ann and built it up. I was a spoiled baby and took over my dad's practice, so I had a base to go into. When I was in my residency, I really fell in love with dental materials. I stayed during that time. I finished a master's program in oral biomaterials, well, through the Department of Oral Biomaterials, and I really fell in love with restorative dentistry. And so a lot of, besides lecturing with Ann on IO, Intraosseous anesthesia, mostly what I talk about is restorative dentistry, specifically for pediatrics. And about a year and a half ago, I moved into a new facility as well. So I went in from a much smaller office to 6,000 square feet and a teaching center. And so I also own the BioClear Pediatric Learning Center, which is, I believe, the only hands-on learning center for our specialty learning, just direct restorative dentistry. It's stuff we're not taught in our residencies. So I try to just elevate the quality of pediatric dentistry in restorative as much as I can. Go to the next. Yep, you want to advance for me there, and thank you so much. And there's just a picture of my new facility. We can go ahead one more. And these are also my courses, so pediatricdds.com. So if you're interested, we book it about a year out in advance. Actually, May, January, March just filled, so May is open. So if you're really looking into elevating your fee-for-service dentistry, that's one of the things Ann and I talk about, is if you really want to learn advanced techniques anterior posterior and change really the way that you do everything in restorative, I would love to see you. And you can scan the little QR code that's there. That's my shameless plug for the night. Thank you. And what we do is I convert the office into the teaching center. So we have a large classroom. We have microscopes, so we stream the video, and we keep it very small. So 13 to 14 docs at a time. I'm big into magnification, so I have microscopes. I think it's important for everyone, especially during patient care or during courses, to be able to see what you're doing live. There we go. And this is my contact information. One thing that you're going to hear over and over again is there is more help than you need or want with these devices. Okay, so my email address is there, joshua@pediatricdds.com. Yes, I snagged that website many years ago. So you can scan for my QR code, and my training center is there, pediatricdds.com. But please, please, please reach out to Ann or I. We are here to help you. We get asked almost every day, and we will hop online with you on Zoom or FaceTime. But we don't want any of you to struggle. So please reach out to us, and we'll continue to talk about that tonight.
Josh, where are you teaching your course?
Oh, we have a course coming up and we're doing one on the road for the first time at Dr. Bynum's office in South Carolina. So I am based in San Francisco Bay Area, but we're going to take the show on the road, and I'm super excited to come out to Holly Tree and teach at Ann's facility and see everybody there. And we hope to make it a yearly thing. And I have bunnies and animals and children. All right, Jordan, you are up.
All right, so we're going to do a poll here real quick. So if everybody could please check out the poll. Just 3 questions, pretty quick. We'll give it a few minutes, let everybody go ahead and do this.
Thanks for completing this, you guys. It really helps us to know, because this is a matchup, right, where some of you may be completely new to intraosseous anesthesia. Some of you may already have these devices. So this really helps us tailor tonight on what, what content that we're going to cover. Good. So for those of you that are new, some of this may be a little advanced, some of the information we're going to talk about. I would encourage you after the webinar tonight to hop back on one of the intro webinars with Ann. And, those are all recorded. You can get access to them all. And that way you can really see foundationally all the basic information. We're going to talk about some of the basics tonight, but that's only part of this. So a lot of this is going to be geared for those of you that already have units. But I do encourage everyone to hop on one of those intro courses at your own time.
So, Jordan, remind me, the participants don't see the responses to the poll, correct?
If I'm not mistaken, that is correct. So we will go over. There's a couple more answers coming in, so let's let them answer that real quick. But yeah, if I'm not mistaken, I don't think they see the results. So I'll go ahead and read them out. So it looks like slowing down here. So, which device do you own? About 60% said SOAN. Only two here have the
Wow.
Sleeper One, and then 37% do not own a device yet. So, who's using these devices exclusively? About a quarter, um, say me and all my patients. Two say only on patients until a certain age. About 30% say occasionally fall back on their traditional syringe. And then about 39%, same amount as don't own one yet. And then what is your delivery method preference? And that is 30% is in cruise, 20% is in drive, and half are unsure. So we'll go ahead and end this poll. Um,
And in that unsure category are the 40-some% that don't own a device yet. So they're like, I don't effing know. I don't know the answer. Right? All right. Trying to get the poll out of the middle of my screen.
Ooh, while you do that, let me make a point I completely forgot to mention earlier. If
Yes.
you have questions, please use the Q&A down at the bottom. Go ahead and put in your questions. We will answer everything at the end. So be sure to stick around for those questions to get answered. But also, if you have any sort of question whatsoever, please be sure to use that at the bottom there.
So one of the reasons that it's really nice that we hold the questions till the end is one to keep us flowing, but also then if you want to go back like Josh suggested and watch any of the recorded webinars, you don't have to listen to the whole thing if you want to catch what questions are coming up that may be a question that you have and you could just grab an answer to it at the end of one of the webinars. So that is the reason, that is the method behind the madness. All right, so back to our mashup tonight. We're going to give you 4 pearls tonight, mixed and mashed in between all of here. 2 are practice pearls Josh has come up with, and 2 I'm going to be contributing about.
So for all of you that some of you may be new to NuSmile altogether. So I was introduced to NuSmile during my residency. So way back, I graduated in 2003. So at that time, I was using their pre-coated crowns, and since then, NuSmile has you can see really expanded their product line. And one of the things they really try to do is find out from us as pediatric dentists what products we need, which products that we want improved upon. Some highlights for me are NeoPutty. I've completely switched. I mean, that was several years ago where I've gone from using IRM. I'm now just to NeoPutty. Bioflex crowns, I think, are phenomenal for the right patients. So if you're looking for an alternative to stainless steel crowns, but you're not wanting to do as many zirconia, in my hands, Bioflex are as fast as the stainless steel crowns. And then we've got chairside space maintenance appliances, which are phenomenal if you have space loss, much better than other brands. And tonight we're definitely talking about SOAN and Sleeper One. If we get to it, we'll talk a little bit about scanners. But if you have a question about scanners and you want to know clinically what we use them for, I'm happy to talk about that. And new products out now, varnish and SDF and sealant, new enamels out now, and I've got some on my desk.
I put this slide in because when I first got exposed to these devices, well, yeah, 2 years ago, someone said something intraosseous anesthesia, and it was like it all flew together as one word or one sentence, and I pretended like I knew what it was, and I was thinking, crap, I know like we probably learned that in dental school. I know we didn't talk about it in residency because we didn't do it. We were learning how to numb baby teeth. Like we just, it was never on my radar. And I thought it was something that was reserved for oral surgeons. So to me, it's two big, scary words that I really had to break down. And I'm trying to, if you feel the way that I felt, I just want you to know that intra means going into, osseous means bone, and we're injecting anesthesia there. So all this means is injecting anesthesia into bone. Any bone, right? It could, any bone. We're dentists, so that's what we're talking about here. And this is where Josh is going to even take a deeper dive so that you have in your head what we're talking about when we're telling you your landmarks and where you need to inject versus these other anatomical places of delivery.
Yeah. The lexicon, the words that we use, especially for those of you that already have these units, I think it's really important to make sure we're all using the same vocabulary, that we are using these to deliver a drug to our patient, right? So I think it's important that we use the right terms. And I think it's important to understand a few of them. So number one, intraosseous, and Ann talked about that. That means that we are, injecting that anesthetic directly into bone, or we're passing through bone. Within that heading of intraosseous, there's really two main headings there. Number one is osteocentral. That term is important because the goal is to pass our needle through the soft tissue, through the cortical plate, and then into this area of cancellous bone. If we can fully inject into this area of cancellous bone, we have a much better spread of our local anesthetic. And so my goal always is to give an osteocentral injection. Now, we can't always give that. And why is it? We'll talk about this later on tonight. But one of the things we need to remember for teenagers is, really these devices in my hands, I know in primary dentition, I can 100% give an osteocentral injection. For mixed dentition, no problem. Up to 14, I find in my hands, I've used my standard syringe, I think maybe 3 times in over a year with patients that are under 14. What we need to remember for teenagers is because we're manually penetrating this needle through bone and we're only using a 9mm needle, you're likely not going to be able to deliver an osteocentral delivery of local anesthetic. What do we mean by that? We're mostly giving intraseptal. So if you look at the diagram here and you think about you're giving a teenager an injection, we only, in most instances, are only going to be giving that injection really around the interseptal bone. So the spread of our local delivery is not going to be as great. We're not going to be true osteocentral injection as we would for our primary and mixed dentition. So don't be worried or don't think you're doing something wrong with your teenagers if you're only getting 2 teeth numb. You've got to remember you're mostly giving an intraseptal injection. You're still going to get your patients numb, but you're just not going to have the spread that you would think that you should have, with a younger patient. One of the key points is that, anytime I've got to use a new piece of hardware, I remember getting my unit, I was worried about it, and I wanted to learn everything. One suggestion I have, and once everyone gets these units, they're excited, they want to talk to parents about it. Oh, I have this new thing. Parents don't like necessarily that you have new things. So the way that I describe these units is that, this is basically just a digital device, or it's a digital pump. But the idea of a intraosseous injection, this has been around since this is the 1900s. This comes from, a journal in France. So this is not new. The electronic delivery method that we're giving is new, but not the idea of the intraosseous injection. Okay.
So what Josh is saying is everything's evolved up until this came into our country 2 years ago from France. This is what we all were left with to help treat our patients. And now we've got this, thanks to NuSmile and Dental High Tech stepping up and stepping out and, hiring the legal teams and investing the money and the time and making the relationship so that, we can have these now, which is super cool because none of us on this call would would be doing this. We're too busy seeing patients. So this is what the devices look like. One is cordless, that is the sew-in, and then the sleeper one has the cord. I do think that most people do prefer the sew-in, and the reason being that it is portable, and you can take it room to room, you can take it practice to practice, and you're not having to deal with the cord. The main differences are the portability and the cord. The sew-in it is much more of a computer. It has a lot more bells and whistles on it. And the container that holds the anesthetic is a little bit longer, whereas the sleeper one you plug it in. It does cost a few $100s less. It is intraosseous anesthesia for dummies. It does not have a bunch of buttons on it, and the container is a little bit shorter. So we have 3 of the sew-ins in our practice, and we have 1 of the sleeper 1.5s in our practice. And the reason it's a sleeper 1.5 is it's the 5th evolution or the 5th version of this device, whereas the sew-in, it's the first version of this device. And the nice part about the sleeper 1.5 is no one's ever pushing buttons to mess up the setting. You can be confident that when you go in that room, if you have it on drive, cruise, stop at a half a carpule, speed up, slow down, whatever, it's not going to change. Whereas this sew-in has so many buttons on it. And if you have steri techs and assistants and hygienists using it and moving it around a lot, you do have a higher tendency of messing with the settings. But I don't really care. I feel like I've used the devices long enough now that I'll go into any treatment room, pick up any device. If it's switched from cruise to drive or stopped here, it's something it becomes innate to be able to troubleshoot it. So I'm going to give you the first pearl tonight. And this is something that we developed and continue to work on in our practice. And it is the 30, 60, 90-day evaluations when you are onboarding and hiring new team members, right? You want to set them up for success. We always say we're not, kicking anybody out until we're sure we've given them all the tools in the toolbox to do the job that we're requiring them to do. And we're constantly learning and growing and changing all of that. And one of the things we did is we developed these 30, 60, 90 checkoff sheets. And you can talk to your teams and figure out what you think needs to be on these sheets. But it's extremely helpful. We make it available to the person that's onboarding, as well as the people that will be helping with the onboarding, so that you can see and they can know, hey, in the first 30 days, these are the things that we need you focusing on. And your leads are going to circle back with you every single week. They're not going to leave you stranded. And they're going to circle back with you and be like, have you gotten help with this? Do you need more help with that? And then every week they sit down and the person says, and we have it for clinical and we have it for admin, right? So they sit down with their lead, or if it's you're the lead, you're the doctor, you sit down with them and say, have you got this? Do you feel like you've got this skill under, mastered? You've got it mastered. Yes. Okay. Check the box. And then maybe you've looked at what they've accomplished and you're like, oh gosh, I still think you're on the struggle bus with that. So, right. That's a growth opportunity. So these are just easy hacks to help you provide growth opportunities for team members. And it makes it more fun than just like, you've got it, or you suck, or you need more work, or whatever. So we just make it fun and say, you either mastered it, you're still on the struggle bus, or we need, we got to put up the flags here. We need some help. So let's go back to the devices and talk about what is the benefit to the patient, right? I mean, at the end of the day, everything we're doing should be patient-centered and patient-focused. So the benefits of using these devices to the patients are no collateral numbness. No more of this going on where whoever's taking call after hours gets the phone call that they've gone to a minute clinic and somebody there has told them they're allergic to anesthetic and they need a full panel and all this nonsense, right? And it hurts. It's sore. Parents get concerned. They're nervous about why it's like this. So this no longer happens. There is no numbness in the lips at all after you use these devices. So it also means, unless you're doing an extraction, you don't need to put a wad of gauze in a kid's mouth because you're not worried about them chewing on their tongue or chewing on their lip. And what benefits do they provide to us? This dentist right here, or hygienist, her hand after holding that syringe that long for me going on 30 years, and I do 10 ops a day for 30 years, that is not a good, that is not good for ergodynamics, let's say, especially when you're, you know, what is it called when you're pulling back and checking for blood? What is the word, Josh?
Oh,
Help.
your
Aspirating. Thank you. Thank you. Thank you. And the patients numb immediately. Huge benefit for us, right? The faster we can help this patient, the less anxiety they're going to have, and the more patients we can help in a day. So patient isn't laying there anxious, nervous. You can get to work right away. You can pick up your handpiece, you can pick up your forcep, your elevator, whatever you're picking up, and you can work immediately. That is a benefit to both of us, the patient and the doctor. So more benefits of intraosseous anesthesia, Josh.
Yeah. So the if I only had these devices just for primary anterior teeth, that would be fine. Um, you know, like Ann had mentioned, oh, you'll have to fast forward for me here, Ann. Like Ann mentioned, the ability to give an injection without having your patient feel any pain is first and foremost the most important thing to me. I can confidently tell you that 9 out of 10 injections, as long as I'm doing anything correctly, my patients will not feel a thing. If they are feeling some pain, and we'll talk about pressure here later on, but if they are feeling pain, it's usually a technique issue. And time again, we see people are posting that they're having, pain with that first step, and we'll talk about that tonight. But I rarely ever have to give it a palatal. If we do give palatal, it's different than what you're thinking. We can just forward through all these, Ann. The biggest thing for me is I've not had one patient with collateral numbness. I can swap sides without an issue. So this whole idea of a midline no longer exists because we're not worried about giving an IA anymore. I did it today. We had patients scheduled for RS and T, but they were cooperative. We had a cancellation. We had lots of extra time, and I was able to jump to the other side without worrying about giving a bilateral block. I really don't like doing. The number of sedation that I have a parenteral permit, so I can do oral, IV, IM. But I will tell you that I don't even actually remember last time I did conscious sedation. I still do GA, but I have 2-year-olds, or this patient down here on the bottom, very, very anxious patient. Normally that would have been 3 to 4 injections for me, but I gave this patient 1 IO injection between O and P down there, gave them a half a carp of 1 to, I believe I used 1 to 100,000 septo here. They were immediately profoundly numb, took out all 4 teeth. Patient did not feel a thing. And I love being able to tell patients afterwards, if they're just having, maybe composites or crown and back, no, go ahead and eat right away. You don't have to wait, especially those children, you're seeing right before lunchtime. And I know that just overall my behavior is going to improve with my patients because I'm able to group appointments much more than I did in the past. And keep on going. All right. So, just to add a few things here, I never realized how much crying bothered me. And I know that sounds funny as a pediatric dentist, but I really just don't for restorative. I mean, sometimes we'll have issues just overall behavior management. They're scared to begin with, but I cannot tell you the last time truly that I've had a patient cry because of the injection. They really just don't feel it. And we're going to talk about we have a lot to go over, so we can keep on going through these. We can talk about how we avoid, having pain. But most importantly, if you are having collateral numbness, you need to reach out to us, okay? There's something going on. Usually it's your first stage, you're giving too much local, or it's a positioning issue, but you should not have collateral numbness whatsoever. And have you ever had a numb lip at all after IO? You've been using these, I'm just past a year. You're doing this longer than I have.
No, I haven't. And I think it's where people get in the weeds on anesthesia versus paresthesia. Like you said, you're giving a lot in the first injection, or it's dribbling around as you're pulling it out. And then you ask a kid, you're like trying to figure out, are these devices working? I don't really know. Is it hooey? Because then you're asking a 7-year-old, hey, is this numb right here? And they're like, oh, yes, it is. Well, they don't, it may feel a little funny, but that doesn't mean it's numb. I wouldn't recommend like jabbing them with an Explorer right then because I think it's just paresthesia, not anesthesia. I don't think it's enough that you could do a procedure. So these are just our guidebooks. If you buy the Sewing or the Sleeper 1.5, I mean, everything is right there. They're going to set you up for success, but everything is baked into these books, everything you would need to know. And anything you want to add on that, Josh?
Yeah, so there's this thing called onboarding. And what you do is it comes with all the things you need to know. I beg of all of you, do not kick that over to your staff, because I will tell you that majority of the calls that we get when someone has a new unit and they have questions or problems is because they delegated the onboarding to one of their team members. These are I want you to remember, these are devices. We're delivering drugs to children, right? So we need to take it seriously. The instruction guides are excellent, but I do want you to really make sure that onboarding doesn't take long. NuSmile will give you a free box of needles, but you need to go through the onboarding yourself. If you have problems, one of the first things Ann and I are going to ask you is, did you complete the onboarding? Have you looked over the instruction guides? They're very thorough.
All right, Josh, tell them how it works.
Okay. So let's talk about why we need an electronic device. I don't know, 10 plus years ago, I tried out the X-tip. It was specifically for patients that had hypoplastic molars. And the problem with the X-tip is you're delivering the local anesthetic manually. So even if you penetrate, someone posted a couple months ago, they said, well, why can't I just buy these needles and use a standard syringe? You could do that, but here's the problem. Number one, the manual delivery, you're going to deliver way too fast. There's no possible way you can give drop by drop delivery of a local anesthetic by hand. It is impossible. The reason why that's important is really twofold. Number one is you're going to give way too much local too fast. So patients and children will feel pressure there. And then number two is we need to minimize the amount of spread of our anesthetic. Now, I'm not saying we don't want this to go to multiple teeth, but if you're giving with too much pressure too fast, you're going to have much more of a spread over a generalized area, and you're not going to get that immediate, profound local anesthetic that we're craving here, that we need. So now the difference is, we can go to the next slide there, Ann, is electronic delivery. So you have to be able to give this drop by drop. You'll see a video here in a minute, but this has to be with an electronic device. Please do me a favor and don't buy any other units that are on the market if you're giving intraosseous anesthesia. These devices are the only two that have clearance to give local anesthesia via the intraosseous method. The other units are basically electronic pumps. The algorithm and the speed of delivery and the pressures are not dialed in for electronic delivery intraosseously. All right, so let's talk about diffusion, okay? When we use these devices for, let's say, a teenager, what we're typically going to be able to deliver, we can fast forward a couple of slides here, Ann, is that in a perfect world, on the maxilla, I would love to be able to get 2 teeth numb distally and 2 teeth mesially. This will happen very easily in the primary dentition, okay? But for teenagers, we talked a little bit earlier about the difference between osteocentral versus intraseptal. So if you can get more than 2 teeth numb for a teenager, you're doing great. But I will guarantee you'll get profound anesthesia in between the 2 teeth that you're delivering your IO with. Now, if this is a patient with primary dentition or mixed dentition, you can pretty much guarantee you're going to have 2 teeth distal to where you inject and 2 teeth mesial that you inject that have profound anesthesia. The lower arch is a different story. So there's a bias of blood flow on the mandible from distal to mesial. So you're almost certainly guaranteed to have anesthetic to be numb fully, 1 tooth distal and 2 teeth mesial. All right. Again, different than teens. If you can get more than that, great. But for our primary dentition, our mixed dentition, 2 and 2 for the upper and 1 back and 2 forward for the lower. So this is a 3-stage technique, and each stage needs to be performed exactly how we show you. I've tried to go off label and do things differently, and I've come back to just following the instructions. So number one, we've got to make sure that we have profound anesthesia in the papilla. If you find that you're having a patient that has a numb lip, you've gone overboard here. All right. So first step is to have profound anesthetic delivery just in that papillary triangle. We'll show you what that looks like. And we're not only numbing the papilla, but underneath there, we've got to numb the periosteum. Then step 2 is we change our position and we're actually penetrating through the bone. You will get, you do get 2 different size needles in your box. What we use 99.9% of the time is the 9mm needle. And someone's already asked a question, I'll talk about it. Risk of damaging developing tooth buds. That is not going to happen with a 9mm needle, okay? If you are getting anywhere near a developing tooth bud with a 9mm needle, we need to talk, because you've got to imagine you're not burying that needle all the way to the hub. You're going a couple millimeters short of that. So by the time you get through the soft tissue and bone, you're only, maybe 5mm into the cancellous bone. You are miles away basically from that developing tooth bud. So we penetrate through the bone, and then we use our electronic device to administer it local. I think a great way to describe this, it's an electronic pump. So I tell parents, I'm numbing just in a different way with an electronic pump, but the anesthetic I'm using is the same one we've used my entire career. All right. There are 2 pedals. And one of the things we want to point out to you is if you are stepping on both, the small pedal always wins, meaning that we're going to step on the small pedal for the first stage of our soft tissue anesthesia. I have noticed that, and one of the things I'll talk about is the mantra I go through, but you really need to step on the center of the pedal here. If you don't have good foot placement and you don't know exactly where your pedal is, it's easy to step on slightly to the side of that small button, and you may hear a click, but you may not be delivering local anesthetic. So one of the things that I always do is before I go into the patient's mouth, I will test it just for a second to make sure that the foot pedal and the handpiece itself, they're talking to each other. All right, you can keep on going forward. Yep. And then the big button is actually to deliver the local anesthetic. So small is just for that first step, just for the papilla and soft tissue. And then the big button is going to be for actually delivering the bulk of your local anesthetic. The 2 other buttons on here, on the upper right, just controls the speed. B is for bone. So you see that you've got pink and blue here. You're going to leave this vast majority of the time on blue, and then on the upper left, your team members or you use that just to retract the plunger.
So I'm going to show you some examples. This is actually a patient in our practice. And you got to get really good at remembering to look at your x-rays, because you can't give an intraosseous injection if there's nothing osseous to inject into, right? So you got to think about your abscess teeth. If there's no bone around there, you got to punt. You got to find another location to inject into. Josh, wait, hold on. I'll figure it out.
Yep, you got it.
Well, I don't know if I've got it. Hold on. This is in my way down here. Like the play button,
Yeah,
I can't
be able to move that to the side. There you go.
There it goes. So this is stage 1. And you can see how flimsy that needle is. It bends. The closer you choke up on the syringe, the better. See how my hand is way up close on there? Let's see if I can jump over here. And now I'm going to do stage 2. I was doing both sides of the mouth, so videoing was just easier to show stage 1 on the one side and then on the other side. I'm going in, I feel it hit bone, and then I try to pull back. I didn't feel like it was in bone enough, so I went in more. I'm twisting, and now it won't come back at me. So that's a good lipness test to make sure you're in bone, is if you give it a little tug back, and I mean a little tug back, and it doesn't come with you, then you're pretty confident that you're in the bone. And again, this is the x-ray that goes with that side of the mouth, and I am making sure that I have a landmark that I'm trying to fall into with the tip of that needle. This is Dr. Nash's patient, and he's going to show the same thing here. Great purchase points. Twisting is a major hack. Being really choked up close to the end is a big hack. And he's doing stage 2. And he's just showing it blinking. All right, pearl number 2.
All right, I'm up. As we know, as pediatric dentists, we're very different than, Dr. Matt Bynum, who may see one patient for 4 hours in a row, is doing full mouth rehab, right? So one of the things I think that is really key if we want to maximize our schedule is actually knowing how long each one of our operatives is scheduled, and if that's appropriate, right? Are we booking too much time, or are we booking not enough time? Now, if you're a startup, this is not as important, but if you're a busy practice, just an exercise to think about, especially if you have a new associate, so you know how to schedule them. So one of the things that we do anytime I have a new associate, or even if a procedure changes, we redid this when I brought Sew and Sleeper 1 in our practice. So we have a guide here we write down all these times for each appointment, and we do this for a couple weeks. So everything from how much time that patient was scheduled all the way to when the room gets turned over and the doctor walks out of the room. Okay, so you can do that for sealants, you can do that for SSCs, really for any of the procedures. And then what we do at the end of that time, after a couple weeks, is to compare the time that we have scheduled to the time that would actually takes us, right? And what I've always found doing this is I wind up saving usually at least 1 to 2 ops a day that I can add to the practice, because often we have scheduled too much time and we get to the end and realize, that operatory was just sitting for a long period of time. So especially those of you that don't have, that you may only have 2 operatories to work out of for restorative, it's a good idea. You'd be surprised on how much underbooking or overbooking you have. So this is just called a time study. You can take a screen print here. If you need the slides, you can reach out to me. But I really would suggest everyone doing this, and it helps everything flow faster in your office and to be more productive. All right. One of the issues that we often hear from docs is they're having pain upon this initial penetration. So, Ann, go ahead and just go through these, okay? Yeah, we can go to the next one. One thing I really want you to concentrate on is if you take the papillary triangle, right? So if we look at the papilla and you were to split that in half, what I don't want you to do is take the tip of your needle and enter in halfway in the middle of that papilla. The problem is all of us are heavy-handed, and as you give that injection, number one, you need to realize that you're having fluid come out of the end, right? So it's going to be going past the end of your needle, obviously. And number two, as we work, especially if you're new to these devices, you may move or your patient may move. And actually not may, you probably will. And the closer that you get to the adjacent tooth, like number T there, the closer you're going to get to the PDL. So if you're having pain, vast majority of the time is this you moved into lateral and you're too distal in this case with the needle. So you want to be at least 1 to 2 millimeters away from the actual middle of that papilla. The other great tip that I learned from Dr. Prin is don't think about poking. The needle is so long and so sharp that you do not need to really put any pressure at all. So I actually slightly, not purposely, bend the needle, but I'm just putting a little pressure on the needle down. When you do that, it's going to enter the soft tissue without a problem. And I find you're less likely to drift too far distal. The goal is in the middle of that papillary triangle, you want to have that entire area blanched. Okay, we can go to the next slide. Perfect.
All right, so I showed you the one video with the blinking lights, and if you're in the 50 something or 40 something percent of people who don't have a device yet, or are just learning about this for the first time, the colors are put on, the blinking lights are put on the devices to help us. They talk to us through the procedure, and give us a lot of good information and feedback. And when we're using the Sleeper 1.5, the light is circumferential. It's around the base of the unit. So you can see it from, if you're standing over the patient, you're at 12 o'clock, you're at whatever, wherever you're sitting in the chair, you'll be able to see that light as it's talking to you, right? And Josh said earlier, blue is for bone. So when it's on the blue mode, you know that you're using it for an intraosseous purpose. Because one thing we probably didn't say that you may not know, and I didn't know this when I first got the devices, let's say you aren't going to give it intraosseous. Let's say you've got a dangling over-retained tooth and you just have a bunch of tissue around it. Now you're ready to give an infiltration, right? So you don't have to pack this device back up on the counter and pull out your traditional syringe. You can use these devices for any type or style injection that you want to or need to give. If you get off on giving inferior alveolar whatevers, you can use it for that if you want. But if you don't have bone, then you're going to want to use it in the different setting for an infiltration. Anyways, back to this. So blue is for bone. It tells us we're ready to give an intraosseous injection. Pink is if we need to go into the PDL, intraligamental injection. And orange will be if we're going to give an infiltration or a block. And these are easy. You can switch between these modes very easily using the foot pedal that we showed earlier. You just tap on it at the very top and it will switch to whichever mode you are needing to use it in. Now let's talk about the Soin. With the Soin, again, a much more robust computer system here. One of the downsides that we're hoping to see in one of the different versions, if more versions get made, is to see communication with lights circumferentially on this device. Because right now it's just on one side and you find yourself either asking your assistant what the lights are doing, or you're crooking your neck around, or you're twisting the device to see what the lights are telling you. But go ahead, Josh.
One of the things that I think it's important to let your teams know when you're teaching them how to set up these devices, they don't need to tighten that needle. It just needs to be enough threads that it's on, because when I pick up the device, depending on where I'm going to give the injection, I'm going to rotate that needle so the D is facing away from the bone or away from the soft tissue. And if they crank that down, it's going to be actually a little hard to move.
Right. And the D that you see right there stands for dental high tech on the end of that needle. To Josh's point, needs to be pointing buccally or facially as you're giving the injection, because it's telling you the angulation of the end of that needle, that scalpel-like end of the needle. And if you don't have it right, you are going to hurt your patient. So like Josh said, don't tighten it all the way down. Just tighten it a few threads so it doesn't come off. And we like to make sure that that D is lined up with the rest of the device. Pink on here is for an infiltration. There is no orange. And then the lights go up. So if you're using the device and you've got it in blue for bone, which is intraosseous, and it starts blinking at you slowly, that means it's delivering anesthetic. If you try to stare at the plunger, it literally looks like it's not moving, and you will trick yourself and think it's not moving, and then you'll take your foot off the pedal and the device has to start all over again and ramp back up. So keep your foot on the pedal. If the light is blinking, trust that it's doing its job. When these lights start to go up, it's telling you that the device is facing pressure at the end of that needle. You are, it's getting some pressure at the end there. And when we get to about 3 blinks on this needle, you need to start paying attention, because Houston, we have a problem. The problem can be a few different things. It could be that, it needs to slow itself down so that the anesthetic can disperse through the tissue a little bit slower. It could be that you have the end of that needle pressed right up against some cancellous bone and the liquid can't get out the end of the needle. Or it could be you've got a spicular bone in the needle. So the easiest thing to do when you get to this point, or the best thing to do, I should say, when you get to this point is trust the device. It's a computer, a very smart computer, and a lot of times it will figure it out and it will just slow down the cadence of delivery to adjust for that back pressure. What I would tell you not to do is to take your foot off the pedal, because if you take your foot off the pedal, it restarts it starts out, because what happens is it delivers the anesthetic, it delivers it slowly, and then it ramps up. So now you're back down to going super duper slow again. So first thing, trust the device. Second thing, if you can't get it corrected, is to back the needle up a little bit. Try to get it off of that bone. Those two things right there usually do the trick. If you don't pay attention, or you let it just do its own thing and you get to 4 and you don't make the device can't figure it out, you don't make any adjustments, the device is going to shut itself off because it knows now that it is not a safe environment to injecting anesthetic into, and it's going to shut down and the plunger is going to retract. So before we get to this point, we want to try those different things. And the last resort would be that maybe you do have a spicule in the needle and you need to take the device out and replace the needle, would be my recommendation. Josh, any comments on that?
One of the things I want everyone to feel okay about is these units are reading the pressure specifically for intraosseous delivery hundreds and hundreds of times a minute. It won't let you get in trouble. So if it's truly that you don't have a blockage and there's just too much pressure building up into that cancellous space in the cancellous bone, it'll back out on you. Okay, so you're not going to have a problem. Someone was asking about also earlier about developing tooth buds. You're not going to have a herniation of a follicle, right? It's reading the pressure. We do need to remember, because it's delivering the local anesthetic under pressure. Joey asked a question, I think we'll answer it now, about anesthetic, leaking out in the mouth. We need to remember, especially the more anesthetic you use, if you go from 1/4 to 3/4, that you are delivering under pressure. And if you as soon as you finish delivering, if you pull the needle out right away, you're likely going to dribble some local anesthetic either from the tissue or from the device, more likely from the device itself. So if you're worried about that, routinely what I do is I'll come off the button and just give it a few seconds and allow that pressure to dissipate so you don't have, excess solution coming out. But there are times when I haven't done that and it's actually squirting out the end. It's not delivering more local anesthetic, right? It's just there's been pressure that's built up in there. One of the other, Joey had also asked about tasting bad because the solution's coming out. Please remember, if you're using an isolite or a device similar to that, what I will do is I'll put the isolite in first, then give your local, because you can start working immediately, right? So you already have the tongue out of the way. You're not worried about them tasting anything bad. And you don't have to worry about giving a block and then waiting and then putting the isolite in. So just go ahead and put it in, give your delivery with the isolite, and then just start working. If your patients, what we do routinely keep chairside are little xylitol wipes. So Spiffy's or any of those brands, because they just open up as a wet nap. And it's, I think it works better than water because at least it has some flavoring in it. So we leave little grape Spiffys we use for nursing babies. We leave it in all the operatories. If a patient's complaining, they just stick out their tongue. I wipe off their tongue, and then we keep on working. All right, let's talk about local anesthetic selection here. I want to go through this, pretty quickly. So number one, topical. And probably, I don't know, she probably did the same thing I did, was a little freaked out right away, and the first couple weeks used topical. And that I maybe did that for 2 weeks, and I do not use topical anymore. Once in a blue moon, if it's just for an over-retained tooth and I'm a little worried, behavior-wise, once in a blue moon, I'll use topical. Maybe if topical comes out once a week, I would be surprised. You truly do not need it. I'm telling you that 9 out of 10 or 9.6 out of 10 of my patients do not feel the injection whatsoever. And I find it's just a hindrance because, trust me, I had a filling done a couple months ago, and honestly, the worst part was just getting topical in the back of my throat. So you really do not need it. And, it says here you can put cotton distal to area administration. If you're using an isolate, what many people do, just put the isolate in, give your local, and you're good. And it's really kind of just up to you. Now, for both devices, we're using Septicane. Could you use lidocaine? Yes. There are many reasons why that I think Septicane is preferable to Articaine, but let me just quickly summarize this. Articaine, at least in the US, comes in 4% Articaine and either 1 to 100,000 or 1 to 200,000 epinephrine, okay? Vast majority of the time in my practice, Ann will tell us she does anything differently, I'm using 1 to 200,000. If I have a hot tooth, if I'm really worried about, an infection and I want to localize the anesthetic in one area, I'm going to use 1 to 100,000, but vast majority of the time I'm using 1 to 200,000. Especially if you're using on a teen, I would highly recommend to only use 1 to 200,000 because we talked about earlier that most of that delivery is interceptal. I don't want to dump, a half a carp of Articaine with 1 to 100,000 epinephrine, in that papillary area. The only times I've seen people that have had issues with a little necrosis in the papilla is over delivering or teenager and using 1 to 100,000. So we like Articaine. It, diffuses to the bone faster. It's metabolized in the plasma instead of in the liver. So our suggestion is just always use Articaine. Okay. The only time I've ever not used it is I had a patient that the physician said they couldn't have epinephrine. And then I grabbed another carp of anesthetic from the oral surgeon. I don't even remember what it was now, but that's the only time I did not use 1 to 100,000 or 1 to 200,000. This is an important point as far as our time. And can you go to the next slide? One of the things we need to remember is timing wise. You can fast forward here. The delivery and the length of anesthesia time for IO is shorter than a block. Okay. If you think about, I couldn't even imagine these days giving a block to a 5-year-old. Just haven't done it for over a year, but it's almost like trying to numb the finger by numbing at the elbow, right? If you deliver local anesthetic here, you're going to have a lot bigger pool of local sitting around, so the patient's going to be numb longer. With 1 to 200,000, we get about 30 to 45 minutes of profound anesthesia. Okay? 1 to 100, it's a little longer. So that's the other time that I'll use it. If I'm definitely thinking this is going to take me a little bit more time, I may use the 1 to 100,000. But because it's so easy and fast, if I have to, top them off somewhere in the middle of the procedure, if it's longer, not a big deal to do. The other reason why these times are important is some people have let us know that they're noticing their patients have more pain, after procedure with IO delivery. And I will tell you that my theory is all of those patients, or most of them, had pain later on because of the dentistry that you did. You just had a geographic success because they were out of your office. If you give a block and do a pulp or do an extraction, that patient that's numb for 2 hours, they were still not so happy. It just happened to be at school or at home and mom was hearing about it, or those kids went back to school and they just dealt with it. But in office, we have a higher chance of hearing about it just because our local anesthetic may wear off while they're still in the office. So number one, you may want to think about preloading with an OTC pain medication, give them Motrin or Tylenol ahead of time. That's not specific for IO. It's just not a bad idea. And then number two, if you're worried about that patient having any pain afterwards, if you just did, some pulps or you did a zirconia crown and you really ran the soft tissue, you may want to think about at the end of that visit re-delivering. You don't have to give stage one. You can just go straight into the bone. You may want to top them off with a little bit of local anesthetic just so they're comfortable longer. Not so they're not complaining in your office, but just so they're comfortable. And that may give that patient time to go home and maybe if you don't deliver meds in your office, maybe have parents give something at home. All right. One other quick tip here. I actually, shame on me, didn't know that. Well, Ann will talk about cruise and drive, but you can set your unit to automatically deliver a certain amount of local. So mine are set at to a half carb. But if you really, the cartridges here that hold the copy of or the anesthetic, it's not marked. So if you feel like it's something that you want to do, you want to mark your containers, you can, set it to run a quarter, see where that it stops, and then use sterilization tape. And then mark your units at a quarter, a half, and three quarters. The other thing that I've seen these used for, if like in my office, we have Sleeper One and So-An, and the containers here look a little different because they are different for both. We have ours marked as blue for one unit and orange for the other.
Very smart. One of the things that people get like so bogged down in is it goes so slow and it's taking so much more time. And so we did some studies on the inside walls of our practice with Dr. Megan and some of our other doctors to show that, yes, this part of the procedure of the appointment does go slower, but it helps speed up the rest of the appointment. So let's watch some of these. First of all, it takes about 2 minutes, it goes about a mill a minute. So about 2 minutes, 1.8 mils in a carpule, about 2 minutes to deliver anesthetic with these devices. However, like we talked about earlier, it's going to slow itself down if it runs into a hiccup somewhere. And if you take your foot off the pedal, it's going to slow itself down. But on average, you can expect about 2 minutes, and 2 minutes can feel like a really freaking long time.
And I have a question for you.
Yeah.
Even with a manual syringe, how fast should we be giving the local since day one? It happens to be the exact same time as you saw on the screen.
Which we don't. No, none of us are sitting there holding it that long.
Correct.
All right, so we're going to watch this little guy here. If I can get this to work. That screen sits right over it.
You did it earlier.
I know. Here it is. So this is sped up, but this is Dr. Megan. And she's going to numb. These are the teeth that she's going to work on.
Like I said, if I only have these units for anterior teeth, it would be worthwhile for me. You notice you do not see him react at all. And that is truly, if you do things the right way, that's the goal. And that's what happens to me 9.7 out of 10 times. 2-year-olds, 3-year-olds, they literally do not feel the injection.
I think she's fixing G. And then she's going to take out F. Super good kid. Giving it a polish. And F. Yep. 7 minutes and 30 seconds from beginning to end of a procedure. We schedule 30 minutes in our office per op. If we can get a kid out of that chair in 7.5 minutes, we've done a great service for that child and for that mom who's taking off time from work or dad who's taking off time from work. And now if there's somebody else in your patient flow, a new patient or a recall that has some issue going on, you've got 20 minutes left. I got 20 minutes left that I can put a patient in that chair. That helps my bottom line. That helps us make goal for the day, which helps bless my team members, and that helps more kids. So right there, if half of you on this webinar don't think you need this device for any other reason, Exhibit A. This is Exhibit A. And this is what sockets look like after these injections. They don't bleed. I don't know really all the wooiness behind that, but you don't have these soppy, wet sockets. They just, I just think they, with all the vasoconstriction, I guess that's it. And they just don't bleed. I've seen nasty molars, videos of nasty molars being taken out, and the socket is like almost dry looking. So here's another patient getting a premolar taken out. Again, we've got it sped up here. And this is Dr. Nash seeing the patient. And in full disclosure, it was his first adult tooth extraction using the sew-in. So he was a little unsure. So he numbed on both sides of the tooth because he just wanted to be he didn't need to, but he wanted to be double sure that he had the patient numb. Can go fully around the tooth with an elevator on the palatal. Nothing sharp. Tooth out. Happy patient. Less than 7 minutes for that appointment, for that kid. That kid gets to go back to band practice or whatever he's doing when he gets out of this chair. There's another little kiddo. This is rough, right? This is where we can be the most compassionate, because if we use a traditional syringe on this little kid, you're going to do the numbing. Then you're going to try to rinse the kid's mouth out. Then you're going to set the kid up, let the parent, console them, or the assistant console them if you don't have a parent in the room, while you're waiting for the anesthetic to work. You're being so much more compassionate, letting this part run its course and be a little bit longer. On the front end. 2 minutes. 2 minutes start to finish. That's a huge compassionate service to that kid and that family. All right, let's talk about some more intraosseous stuff here.
I just mentioned this one earlier because this is really what sold me on the whole process. You can just skip through these. So this was 8-year-old female. Mom had super high dental anxiety. She passed that on to her child. They walked in that day. Mom's crying, patient's crying. And, I don't really have a lot of instances where the ortho says, go ahead and take all 4 lower interiors out, but gave stage 1, maybe that takes 5 to 10 seconds. Second phase, manual bone penetration, patient didn't feel anything. It gave a half a carp of 4% articaine with 1 to 100,000 or 1 to 200,000 epi. All 4 incisors immediately numb. This whole thing was just a few minutes. Probably took longer to put the nitrous on and took it off. Mom's crying with tears at the end, patient's crying. And again, if I only have these devices just for tears, it would be worthwhile.
Boom, right there.
All right. One quick thing to note here, and this came up as one of the questions that people asked on the Facebook group, is why is I'm not getting lingual anesthesia? The thing we need to remember is previously when we were giving a buccal infiltration, let's say, you needed to wait for that fluid bolus to go through the soft tissue, through the periosteum, through the virgin Volkmann canals, and then perfuse into the cancellous bone to the apex of the tooth, right? And then everything's numb. Now on the contralateral side, that local anesthetic needs to flow backwards, right? So we're actually giving it on the buccal. It has to flow through the cancellous bone and then go through the plate to the through the periosteum to the soft tissue on the other side. So I like to always give the least amount of local anesthetic possible. And if let's say for instance, S&T, I'm just doing back-to-back composites, I will try, let's say if I'm using an isolite, only a quarter carp. But it is dependent. I find making sure that you've got lingual anesthesia, that the soft tissue's numb, it is dose dependent. So I find you've got to give a good half a carp if I really want to make sure that I'm getting profound anesthesia 360 degrees around that tooth. And would you find the same way that it's dose dependent for you if you're not getting lingual
Yes,
anesthesia?
it is. And I saw there was a conversation on the Facebook, the Sew-In Facebook group about it, that especially if you're placing a rubber dam, if you're an old schooler and you like a rubber dam, that to have the confidence that it may not be the tooth itself that needs the half carpule, but to have that profound lingual anesthetic, you should plan on a half a carpule if you're going to place a rubber dam clamp.
If you're having, for some reason, if you find you're not getting, profound anesthesia on the lingual, even though you gave that half a carp, it's okay to go, what I will typically do is just go through the papilla on the buccal, pass through to the lingual, and just give enough where I start to see some blanching there, and that's typically just fine. Patient won't feel a thing. All right, palatal access. So one of the big questions that we get is what happens if I'm right-handed and I've got to extract teeth, or I've got to work on teeth on the patient's upper left-hand side. And you can fast forward here. So I was definitely a little worried about giving palatal for patients. Now, this is different than a palatal infiltration, right? That is very painful. You're going to do the exact same steps. Step one, then manual bone penetration, and then deliver your local in the same location. It just happens to be on the palate. So patient doesn't feel it anymore. You just have to, I wrote, don't be a baby. You just got to do it. Once you do these once or twice, you'll realize that it's exactly the same as giving on the buccal. And I always thank Eric Hans for reminding me to do this. I do want to remind you that we get asked a lot, well, why can't I give the initial stage one numbing the papilla in the same angulation as the manual bone penetration? You technically can, but there's a reason why that we teach with the horizontal approach. If you look at this slide here and you see that the doctor is giving stage one vertically, you can do this. Okay, it's fine to, but you have to realize the periosteum is highly, highly innervated. And if you slip a little bit and your patient moves and you take that needle and you pop into the periosteum, you're going to have a very unhappy patient. So it is much safer, at least in my hands, to come in horizontally and give in anywhere in the mouth, to give your initial injection in a horizontal fashion and then switch positions. Have I given stage one manual bone penetration, stage three, all in this angulation? Yes, but you've got to be way more careful, and that's why we don't teach it this way. All right. We get this a lot. If you have infected teeth, how do we treat this? Number one, you've always got to look at your x-ray. All right. If you notice that, you can go to the next slide, Anna. If you do not have good organized bone, like you look here on S&T, not really great bone around here because of the parietus that's there. We need to remember that, especially if you have bone loss and liquefaction, the body has already marsupialized that area, right? And you just don't have good cancellous bone to inject into. So you need to enter that needle wherever it's going to be the most organized bone. Sometimes you need to give some on the mesial, some on the distal, but a patient like this, I would immediately just go ahead and give it on the lingual surface. I know that I'm going to have more organized bone there. I'm not going to worry about injecting, into that area where the sinus tract is. The whole point is look at your radiographs and look for organized bone. It's the same reason why for over-retained teeth that I wouldn't necessarily give an IO if I have an over-retained incisor. There's no point to it. And you have higher chance of not getting profound anesthetic in the soft tissue if you're not giving enough local. So in that instance, I'm just putting it on, you can leave it on blue, or you could switch to another mode and just give, profound soft tissue anesthesia and not into the bone itself. And we already talked about the angulation here, and this is from more advanced slides. So just remember, positionally, you can give it this way, but you just don't want to touch that periosteum at all with the needle. All right, and you have to give it on lingual. Give it on the lingual. I don't care anymore if I give it in the palatal or if I give it, on the buccal or the lingual. It does not matter to me as long as you get into organized bone. All right. Over delivery. We've been asked about necrosis of the papilla. My theory is this comes from a couple things. Number one, a lot of our patients are pickers, right? They sit in the back seat on the way home and they're grabbing their fingernail and they're digging in there. But number two, if this is happening with teens, you've got to be careful. You're giving intraseptal delivery. I really only want you using 1 to 200,000. Okay.
So it's like an ischemic reaction. It's like it's
Exactly.
killing those cells right there, right? And that's
Exactly.
what's uncomfortable.
I had a young patient get a hold of their brother's EpiPen and pop himself in the finger and it turned black. And it's exactly what happens here. It's just it's an ischemic event and you're having tissue sloughing and dying. Right. We talked about this one already. Really, please, please, please don't go straight into the middle of that papilla. Go to the side a little bit. Okay. 1 to 2 millimeters. Here's another key point for tonight. Cancellous bone does not have nerve endings in it besides the apex, the nerve going into the tooth. Someone had asked about, well, they're fine with that first stage, but then when I get into the bone, they're having quote unquote pain. What I find is what they're feeling is pressure. So I do remind, the child that you may feel a little bit of pushing. Sometimes, if the parent says something, I'll tell them it's just pressure. But just know if you're truly through that cortical plate and you're in cancellous bone, if your patients react, it is pressure. And what I'll do is I'll come off the pedal and I may give it a second and then I'll continue. Now that does slow things down. Like Ann talked about, we have that pressure curve, right? So it's going to give slow and then it speeds up. But if your patient have a hard time, I don't have to do this a lot, but I'll come off the big pedal and just step on it again so it ramps up slowly.
All right, I got another pearl for y'all. Golly, can't even talk. Jeez. This is actually a pearl from Jeanette McLean Budd. She gave me this idea. She does this in her practice. These are magnets that we have made, and the center part of it comes out. And so they get a separate magnet that has all of our information on it also. But we take their photo chair side at their new patient appointment and we make this and we put it together for them. And they get to take it home. And it has been like the hugest hit. You can put as much crap in that goodie bag as you want. Even if you put this picture in the goodie bag, they pull it back out and they're looking at it. They love it. The kids love to look at it too. So, because if you think about it, so many photos live on cell phones now, right? Like who's printing out a photo anymore? So this is a really a kind, fun thing to do, and it promotes yourself and it brings joy to your patients. And then, we do the tot spot. Any of you out there doing tongue tie and airway and seeing little ones, get your logo on these little onesies. You can buy all these onesies on Temu and, get some great marketing out there. We send them home with every parent. We ask them to send us some photos and to keep in touch with us. A lot of these babies we see in the tot spot, we then get to see as new patients, like a year later in the practice. So what is the difference in drive and cruise mode? It's exactly like your car, okay? And again, why is my sewing stopping at a quarter carpal even if I'm in drive? So this is what drive mode would look like, right? We're getting in the car and we're driving it. Same exact thing. Foot on the pedal is drive or using cruise mode. When we have our foot down on that pedal and we don't take our foot off of that pedal, that's just like our rheostat. So that's in drive mode, okay? If we want to put it in cruise mode, you set the device up differently and you tap on the pedal and take your foot off of it. And now it's in cruise mode, like cruise control in your car. You're not having to keep your foot on the pedal in your car. You're not keeping your foot on the pedal in the operatory. I used to think I always wanted it in drive mode, just like my rheostat was, because it was what was muscle memory in my head. And then I started to realize, hey, I may want to roll around and grab something off the counter, or I may want to roll over and look at something on the computer. And you can do that. You're literally just supporting the sewing or the sleeper one in the mouth like this. You're once it's in, you're just holding it and letting it do its job. So I can like roll over here and do something. Also, I don't have to have my foot all cramped up on that pedal the whole time and worried that if I slip off the pedal, it's going to restart itself.
I did that today back in court. I did it with one hand. That's not necessarily proof technique, you guys, but I did it today. I was holding my son in one hand and back in court and another tooth in another.
I'm going to show you this because this is what can happen if you're in cruise mode and you take the syringe out of the mouth and you forget you're in cruise mode and you forget to tap on the pedal. And now you've capped the device and you have it sitting on the counter back behind you. And then when the assistant comes to pull it apart, it is completely full of the remainder of your anesthetic. So cute, right? Like that's not what we want. So if you are in cruise mode, you have to remember to tap the pedal again to shut it off so it doesn't continue to drain that anesthetic into the end of your syringe cap there. Talk about this, Josh.
So I think it's important, when we get these devices, number one, although you're excited, I don't necessarily like to tell parents, hey, this is this new thing, and they think that, we're experimenting on their kids with new stuff. We need to remember that we are one of the last countries in the world to get these devices, right? They've been used in France, in Europe, in the Middle East, in Asia for 15 plus years. I like to describe the unit as just a digital pump. Mom, this is what we're using today to numb. I'm using the same anesthetic I've always used my whole career, but thankfully we have a new way to do this. It's just a digital pump. It gives the anesthetic much more slow. I can put it in an area where they don't feel it and they're not numb afterwards. And then we can go into, they can eat and drink right away and all those things. The other point I want to make here is these pamphlets are available from NuSmile. These weren't written just by NuSmile. That many of the KOLs put their 2 cents in here, so you can buy these from NuSmile and hand them out to parents. One of the things you can do too, if you have an internal referral program, it may not be a bad idea to clip some information about your internal referral program to those brochures.
This is what we have in our practice. And Marie Johnson started developing this, and I put my own spin on it to make it match our branding. But this hangs, parents don't come in operatories in our practice, and they look through a window if they'd like, or they TikTok out in the reception room. But this hangs on all the windows outside the treatment rooms, and they can read up on it themselves so they can understand why we're doing this. Great little educational tool. So again, why is my patient experiencing discomfort? I think we went through this. Josh already mentioned, like they're numb for less time, so we're just hearing about it more. So they're feeling the discomfort sooner. And also at the beginning in your learning curve, you're going to be stabbing the patient probably more times than necessary as you're learning this. So when you're in this learning curve and you're calling to check on the patient or the assistant is calling to check on them, they may be more sore because you've been in there experimenting on their child. Is pretty much really what happened.
And when you new to this, I think you did the same thing where you started to practice during general anesthesia. You're the same way. Yeah. So that's just something to think about as well when you're new. If you have your patient asleep, you're still giving local, in certain instances, you may want to think about practicing that.
Right. And this right here, you're in the PDL. That hurts. You don't want to be giving a pressurized injection into the PDL. So these are just a couple of the things. And you're right, we're tricking ourselves. If you did a pulp and a crown on S and you extracted T and you call later and they tell you they're hurting, they're probably not hurting from the injection. They're probably hurting because you just beat them up doing dentistry. All right, we're going to skip this pearl here. And we're gonna, for the sake of time,
quickly, we only have a few minutes left here. So I do the same steps every single time when I give an intraosseous injection. So number one is I'm going to look at my unit to make sure the power is on. The reason why I do this in order is because, and I've gotten burned with this before, is I went to give the first stage and realized, oops, I didn't even turn the unit on. It will shut itself off and there's settings there, but it's set up. The default is so you can give 30 full carps, but first thing I'll do, I sit down, I'll make sure the unit is on. Then number two, I'm going to look at my radiograph. And I can't emphasize it enough to review your radiograph. I'm going to pick my injection site. I'm going to make sure that I have the right local anesthetic selected, suction, my assistant's ready. I've reviewed everything with the parent, and then I'm ready to go. before I give that injection, I want to make sure is the pedal in the right location. It's very easy for the pedal to get pushed underneath the chair, and you can go ahead and give your first part of the injection and put your needle into the papilla, and then realize you can't reach the pedal, and you've got to then come out of the mouth again, right? Patient doesn't feel it, but parent doesn't necessarily want to see you giving that first stage several times. I also make sure that my foot is in the right position, because if I feel like I'm not going to be able to step immediately in the center of your pedal, again, you may hear a click, but it's not running. It's not because it's not talking to each other. It's just you stepped all the way to the side of that pedal, and you may hear the click, but it doesn't fully engage. So it's power, plan, pedal, and position.
So we're coming to the end of this, and now I want you to really think about some things to think about for why you should switch to this type of compassionate way to treat your patients. And I just don't want money to be a roadblock. So we just want to talk about it right out of the gate. There's been some chatter on some Facebook groups about the price going up. And yes, the price did go up. They've tried really hard to keep the price down through AAPD annual session, and they did that, knowing that they were going to have to make up for it on the back end. So this is the new pricing for the devices. The cordless is $31.95. If you buy more than one, you do get some reduction in price. And the Sleeper 1.5 is still under $3,000. So, being married to a general dentist, his toys cost way more money than mine do. I could buy.
That's one implant socket wrench is $3,000, I think.
Right. So don't get hung up on that from a financial standpoint. And the price of the needles has gone up as well. So just to be aware of those changes inside the company. So I'm telling you, give somebody your credit card, get these in your hands. Don't go cold on this. You wanna buy these. I'm telling you. And also, we've got the 100% cost depreciation back. So go ahead and get a couple of these in your hand. Other tips, we want you to be patient with the devices and practice. Don't have a traditional syringe to fall back on in the room. Make yourself use these and practice. Practice on kids that are good. Practice on kids that are young and have cancellous bone. Practice on petite dental assistants. Practice on your spouse and your GA patients. Join the Facebook group. Here's a QR code for it. You can find it yourself, but lots of great information in here. Very kind learning ecosystem. You can post your wins. You can post what's not working for you. It's a great group of cheerleaders in here. I learn something in there all the time. And I have a circle of death on my screen. I don't know why. Does anyone else see it?
We do. There you go.
All right, that was odd. Training, again, very hands-on, very accessible. Chris Malzone, he pretty much runs NuSmile Tech. Great guy, not as goofy as he looks in this photo. Very, very smart. Jordan, as goofy as he looks in the webinar tonight, as he does in the photo. Again, a great asset to the company and to help you learn these techniques with these devices. And Erin Binford, she's another great asset that comes alongside of us. So you can reach out to all these people. They're great human beings, and they really want to see us all be successful to help kids. You got enough people, you can call NuSmile and they will come to you and they will teach and train for you. So we run a study club here in the upstate of South Carolina with over 40 pediatric dentists, and they came out and they did a whole hands-on training for us, which was really nice of them to do.
While you get that spinny circle, and I have to point out, Erin getting her own slide, favoritism.
Lots of it. Lots of it.
Was that your first time going to Buc-ee's?
There you go.
No, gosh, no. And these are just all the places that you can try them out. I mean, we've taught at residency programs. We've taught at military bases. We teach at the Restore courses. We've taught at different dental meetings. So getting the device in your own hand in one of these ways, or having it used on you that's a big aha moment. To see what it actually feels like to be numb is a really big aha moment.
I think we need to get into questions.
Yeah, some final pointers here for everyone. You know the solutions to all your problems and you don't want to do them. This is going to solve so many problems for you and for your patients. We just really encourage you to get them in your hands. Jordan, hit us with some questions while my circle of death spins here.
Yeah, let's do it. So first question, risk of damaging developing tooth buds. I know we talked about this a little bit earlier, but if you want to.
Yeah, if you have the end of your needle anywhere near developing tooth bud, we got to talk. You've got only a 9 millimeter needle. Even if you were to put that entire needle through the cancellous bone, you are not going to get anywhere near developing tooth bud. And these units, again, they have the sensors inside that are constantly scanning. So you're not going to be worried about overpressurizing the system that's here. Yep. And then there was a question, let me address this one because it's come up about upper permanent second molars or second permanent molars in older teens. Here, and Ann mentioned, practicing on your spouse. Here's the thing that I need everybody to remember. What we're doing is manual bone penetration. These devices are not necessarily designed for adults, okay? In my 2 cents, my personal opinion is any intraosseous injection I can give over the age of 14 is a bonus, all right? There is another device that's not available here that's going to be, 4 times more expensive that spins the needle that drills through the bone. And that's why that device is used in other countries for adult patients. But I don't want you to think it's a loss if you can't, lower second permanent molars in older teens. You may not be able to get through because they're not really designed for that. You're taking a 9 millimeter needle and trying to get through, the cortical plate on that patient could be 2.5 millimeters thick. So it's a bonus if you can get a patient that age numb and get a true osteo central injection. Well, you're not going to get osteocentral. You're going to get either transcortical or intraseptal at that point. But thick bone in older teens, you just may not be able to do it. Just not designed for that. And do you want to talk about primary canines before we wrap up questions? Because I know that comes up a lot.
Like where to inject if you're taking out CNH?
You got it.
What do you mean? So the bone distal to CNH can be a little tricky sometimes, actually. And you really don't need to inject there. You can inject right between right between 8 and 9, or ENF if that's what you, depending, ortho case is probably 8 and 9, but if it's decay or something else, it's ENF. But right here, you can inject in the midline and you can get out CNH.
Okay. And sometimes the bone, the canine eminence is thick. And if there are some times I haven't been able to give IO. So what I'll do is just give a PDL with it. I'll just advance it into the sulcus and then just give my, quarter half carb that way. And I find it works absolutely as well. And I didn't want to, misinform people. The longer needles that your units come with, you can use those for infiltration. So I still use them. They won't exchange them out for you, but it's something that's good to keep on hand. Technically, you could give a block with those longer needles too, although I wouldn't use this device. It's really not needed for that. But for infiltrations, the long needles are good to use.
And to add on to that, Josh, exactly. I appreciate you answering that. And then you also get a free pack of 9 millimeter, the extra short needles, just for completing the onboarding. So if you haven't done that already, please make sure to go ahead and do so.
We should make you a test that you did it and you didn't have one of your assistants do it before you give you needles.
Jordan, while I have this slide up and live, can you comment on it real quick?
Absolutely. So these are upcoming Restore courses. Please check them out if they're in your area. They are private workshops that we do. We cover everything. So day 2 is tech day, where you go over the SOAN Sleeper 1 with some hands-on. And then you also can play around with the scanner. Saturday, the first day, is over everything restorative, preventive that we have to offer. It's a full day worth of CE So if you want to join for one of those 2 days or both, absolutely go check it out on nusmile.com. And all the details are in there where you can see where it's going to be hosted and who will be lecturing and everything else. Are either of y'all going to be, y'all want to say which ones y'all are going to be at?
Josh?
I'm going to be at the Newburgh course, and I'm speaking on tech the second day, but I'm coming both days. If you've ever been to the Allison, Chris Malzone and I have presented there, and it's absolutely gorgeous, 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 gorgeous. And I'm going to be there the entire time. So use me while I'm there. You want to talk about anything NuSmile product related. You want to talk about IO. You want to talk about restorative in general. You want to talk about practice management stuff. I'm going to be there to help the entire time. On Saturday, I won't be teaching. So if you want to schedule time with me and you have, questions on things, please do. I'm there to work.
I will be on the beach I will be teaching in Fort Lauderdale. So I'll be in Fort Lauderdale in November, and Dr. Megan, my business partner, will be teaching in Los Angeles.
Oh, nice.
Awesome. And then,
This is just our slide again if you want to contact us. And then if you can, Jordan, hit us with more questions and we'll wrap.
yeah, so I know we talked about canines here. Recommendations for lower canines, upper permanent second molars. And
Second molars, you may have a hard time, getting. If you can get in, great, but there's not really besides what Ann showed you, holding the needle as close as you can to the hub. But you may have to give an infiltration there for, older patients. Like I said, 14 and younger, I can pretty much guarantee you're going to get IO, but just remember, you can still give infiltrations with these devices. And I use it for everything. I don't use a standard syringe really for anything at all. And for older patients, I'll give my infiltrations with my sleeper one and my sew-in.